Good morning, everybody. The topic for today is RH isoimmunization in pregnancy. I am Dr. Saritha, Professor of Obstetrics and Gynecology at Mallareddy Medical College for Women. RH, as you all know, is a blood group which was discovered by Carl Landsteiner and Wiener in the year 1940. This has a group of antigens C, D, E, and E. Of all of these, D is the most important antigen. That's why most of the times you say RH, the anti-globulin also is called as an anti-D. C and D are the minor factors. It's present on the short arm of chromosome 1. D is the most immunogenic, and a person lacking the D antigen is called RH negative. Indian population, about 8 to 10% are RH negative. The rest are all RH positive. That is, the D antigen is present in them. 8 to 10% of the population, they do not have it, but it is more important for the female population rather than the male population, because when they bear a baby with a positive RH positive husband, then there is a problem with the pregnancy. So if you see, these are the antigen which is positive, and when it is absent, the women are called as RH negative. Why is it important? Because of the isoimmunization which occurs. Isoimmunization is nothing but antibodies are produced in the person by the entry of an antigen of another individual of the same species. From the same if RH positive blood is given to an RH negative person, then antibodies are formed in the persons who are not having the RH antigen, and these antibodies will act against any further transfusion. So this RH isoimmunization is a major cause of hemolytic disease of the fetus and the newborn. Pathogenesis, what happens exactly is when an RH negative mother is carrying an RH positive fetus through an RH positive father, then at certain point of time the fetal RPCs which are positive enter the maternal circulation because of feto-maternal hemorrhage, and then the mother develops antibodies. So these antibodies, for a first time pregnancy, the first baby will escape. The first pregnancy is called as a sensitizing pregnancy. The baby will escape any untoward effects because of these antibodies. And again, most of the feto-maternal hemorrhage which occurs during the delivery, and they have a very weak response, IgM response, and this IgM does not cross the placenta. So therefore, the first baby is not affected. Fetal effects of isoimmunization in the first baby are non-severe. It doesn't occur. Most of the times there is no effect on the first baby for a pregnant woman with an RH positive husband, unless she had a prior transfusion, okay, or a prior abortion. Subsequent pregnancy is called as a sensitized pregnancy. Here what happens is RH positive, subsequent pregnancy, again if it is an RH positive fetus, there is some amount of feto-maternal hemorrhage, and this elicits a very strong anamnestic response. Already the antibodies are present, and this IgG response will be there, which causes hemolysis, because these antibodies, they enter the fetal circulation and destroy the fetal cells. This is the fetal hemolysis. Which leads to congenital, because when there is a hemolysis, it leads to congenital anemia of the newborn, and the later effects of this are there will be, because more and more fetal cells are getting destroyed. What happens is there will be fetal hyperbilirubinemia, icterus gravis neonatorum, and sometimes if it goes unrecognized, the fetus might develop hydrops fetalis, which is fatal for the fetus. And this outcome worsens with every pregnancy, or every when she is not protected by anti-D, if she has abortions, with every pregnancy there is the worsening of the outcome of the fetus. Then what is the critical amount of antigen which is required to elicit an RH response in the mother? It is RH antibodies. We have already gone through the pathology. These antibodies coated red cells. They destroy the fetal cells, leading to fetal anemia. Fetal anemia causes fetal hypoxia and stimulation of the erythropoietin, which causes an extramedullary hematopoiesis. So extramedullary, where is the extramedullary? The liver and the spleen they start producing more and more RBCs to counteract the hemolysis which is occurring. This causes the hepatosplenomegaly in the fetus, and this hepatosplenomegaly ultimately causes a hepatic cell failure. And because the liver produces the proteins, hypoproteinemia is seen and increased intrahepatic pressure is seen, leading to portal hypertension. Because of hypoproteinemia, there is edema, ascites, hypoxia. Hypoxia because of the decreasing hemolysis, and the placental thickness, because the placenta in its effort to help help the fetus tries to it becomes the thickened placenta will be seen, and along with polyhydramnios and pericardial effusion. There is effusion of fluid into the pericardial and the peritoneal surfaces. So here you see an RH negative woman with an RH positive partner, and this woman with a first time it is where she has a pregnancy and it is an RH positive fetus. Then this RH positive cells during the delivery or a little bit earlier also enter the bloodstream. So the first pregnancy goes unnoticed and she can have a healthy baby, but she is sensitized and she starts having antibodies. So next time there is an RH positive pregnancy, again a RH positive baby, what happens is these antibodies which are already formed because of the anamnestic reaction, they enter the fetus and they will have the effect on the fetus, as we have already seen in the pathogenesis. Then what are the chances of a RH positive fetus for an RH positive father and a negative mother? This again depends on whether the father is an homozygous or heterozygous. If it is a homozygous positive father, then definitely with a homozygous positive father with all the children will definitely be affected, as you have seen on with a mother who is negative, as you have seen on the left side of your screen. Whereas suppose if it is a heterozygous positive father, that is one big D and one small d, only 50% of the children will be RH positive. The rest of them, and for a human being to express as RH negative, both the antigens of the D should not be present. That is, both are small d. That's why 50% of the children only will be affected. But for a homozygous big D, father with a D positive, definitely 100% of the children will be RH positive. Then coming to what are the methods by which a woman can get sensitized. One of them we are saying is a prior history of transfusion. There is another interesting theory called as the grandmother theory. In this grandmother theory, this fetus, it explains the development of isoimmunization in a primate who has no history of exposure to the incompatible RH blood. So this here is a woman who is a negative, RH negative, and she is not having any history of blood transfusion, but the first child itself is affected, which is surprising because so far we are talking that the first child will not be affected. So what happens is the RH negative fetus and the mother is RH positive. So negative fetus is there in a positive mother. The fetus is exposed to the maternal RH antigen through the maternofetal. Here it is the maternofetal transplacental. Usually we talk of a feto-maternal hemorrhage, but here it is the maternofetal. So what is happening is the fetus is exposed. This negative child is exposed. If the mother is positive, she is exposed by the transplacental vein. The fetus immune system develops the permanent template. So the negative fetus will start having antibodies. But these antibodies will not be expressed, and when this negative child further becomes a mother, so that is the time when the first baby of that negative mother will be affected, because she had this negative baby who is further become a woman has the memory of the antibodies which she has developed from her mother who was positive. So this is called as the grandmother's theory. When the fetus becomes a mother herself and exposed to the new load of antigen, then the immune memory is recalled and secondary immune response occurs. So because of the grandmother being positive, the RH positive fetus is getting affected. So this occurs rarely, but this is also called as the grandmother's theory. Now what is feto-maternal? What are all the circumstances wherein feto-maternal hemorrhage can occur? As you know, first trimester abortion or an ectopic pregnancy or a molar pregnancy, it can occur. And any of the procedures which are done in the early first or second trimesters like chordocentesis, chorioamnios biopsy, which is typically done in the first trimester, and amniocentesis, chordocentesis, which are typically done in the early or mid second trimester. These are the causes wherein feto-maternal hemorrhage can occur. Then attempted external cephalic version, then any manual removal of placenta, any trauma to the abdominal wall, any antepartum hemorrhage, abruptio placenta, and a vagina, of course, a vaginal delivery, a cesarean section, a forceps delivery, or any prior history of blood transfusion. So when you have an RH negative gravida, this is the history you have to ask in case she has any abortions, whether any anti-D was given for an abortion, for an ectopic pregnancy or for a molar pregnancy. Is there any prior history of receiving a anti-D to the, because she is an RH negative woman, was any positive anti-D was immunoglobulin is given to the mother. Then what is the volume which can sensitize? As little as 0.1 ml of feto-maternal hemorrhage can cause the risk of sensitization is 3%, and suppose if it is more than 5 ml, then as high as 65% of the women can get they can have the antibodies. Okay, so abulant incompatibility is protective, because what happens in an abulant girl, suppose if the fetus is O and the mother is B positive, so there is a incompatibility. This is most common, and it is very mild anemia will be seen, because most of the times the IgM antibodies do not cross the placenta, and the fetal cells have fewer anti-A and anti-B antigenic sites, and the adult cells also will not be that much, they are less immunogenic. So it is not because of the ABO incompatibility between the fetus and the mother, there is some amount of protection. Yeah. Then the next thing is, we are talking about the ABO incompatibility. Then what are the fetal effects of isoimmunization? Fetal anemia can be seen on ultrasound examination. Hydrops fetalis can be seen, or fetal anemia. So what are the effects on the fetus are, can be an anemia, can be a hydrops fetalis, or it can be a fetal hyperbilirubinemia. Suppose if the baby crosses this stage and it is born, then during the early neonatal period, on the first day itself, the baby will exhibit a jaundice, wherein it is called as icterus gravis neonatorum. That itself also does not carry a very good prognosis, because here, because of the fetal hyperbilirubinemia, if it crosses after a certain amount, like about 20 milligrams of bilirubin percentage, when it crosses the blood-brain barrier, there is an effect, the baby will present with kernicterus. Then mild form of the hemolytic disease of newborn is, mild hemolysis is tolerated, mild anemia, sometimes jaundice at birth, it usually resolves without treatment. Then what are the moderate one? Moderate is increased circulating bilirubin, which is cleared by the placenta. Okay, after birth the bilirubin is not cleared by the immature level, leading to, this is what we talked earlier, that is it causes a as long as the fetus is in utero, the bilirubin is getting cleared by the immature level. But once it is that bilirubin is taken up by the placenta and cleared by the maternal circulation. Whereas after the fetus is born, the fetus does not have a mature liver, and this causes hyperbilirubinemia, leading to kernicterus, because the immature liver of the newborn cannot clear the bilirubin. Then moderate anemia which is present can be treated in the postnatal. These are the moderate effects. Now coming to the severe effects. Severe effects are severe fetal anemia, then hepatosplenomegaly, erythroblasts in the circulation, liver dysfunction, fetal cardiac failure, fetal hydrops, stillbirth, and neonatal death. These are the severe. Once you have a hydrops fetalis, there is no way we can save the fetus. Then what are the signs of fetal anemia? The signs can be polyhydramnios, hyperplacentosis, an effort by the placenta to increase transfer oxygen, but the available fetal blood cells are red blood cells are low. Then fetal ascites, hepatosplenomegaly, increased right atrial size because of the hypoxia and the hypervolemia. Then fetal hydrops, wherein there is generalized edema. Now, if it comes to hydrops fetalis, this is a ground glass. I mean, it is an ultrasound diagnosis wherein you can see a ground glass placenta, pleural effusion and pericardial effusion, Buddha posture is seen of the baby, and the halo subcutaneous, you can see the halo sign of the edema around the scalp. You can see the skull, and around that the pericranial edema is seen, which is called as the halo sign. And when you do MCA of the MCA PSV, it is more than 1.5 mean of. So this is a fetus of Hydrops fetalis, and typically it is called as a Buddha posture, wherein the fetus will be in the cross-legged position. Maternal effects of RH alloimmunization, hyperplacentosis can cause a preeclampsia. Then because of chondrosynthesis and amniocentesis, either to diagnose or to treat the condition of fetal anemia, there might be complications to the. Then RH negative, when a woman comes to the OP with an RH negative, you do a routine blood test and you ask for the blood grouping and RH typing of the mother, and you see a negative mother. The first investigation which we ask for is the husband's blood group. If it is a negative husband, then we are happy and there is no problem, because both are negative. The children will definitely be negative, because a negative blood group can only be had when both it is homozygous negative. Okay, whereas a positive can be heterozygous, but negative should always be homozygous negative. Okay, so if it is a positive husband, we ask for the indirect Coombs test. So indirect Coombs test, we do it for the woman, and direct Coombs test is done for the baby. So if the indirect Coombs test, which you have all learned to do in the microbiology, if it comes as a positive, remember one thing, it's always the maternal, we do an indirect Coombs test, whereas for the baby it is a direct Coombs test. If this indirect Coombs test is negative, then the other investigation which can be done is the non-invasive investigation. This is preferred because if we know the blood group of the fetus with the womb of the mother, we can know this by doing a non-invasive fetal testing for RHD gene. This is called, you do the cell-free fetal DNA is done from the maternal plasma, so that if it is, you see the cell-free fetal DNA, if you are having negative blood, then definitely negative RH group in the cell-free fetal DNA, definitely you can rest assured that the baby is a negative baby and there will not be any effect on the fetus. But if it is a positive thing, then you have to screen for alloimmunization. So what are the, how many times do you screen the maternal mother for the indirect Coombs test? First you do, in the first pregnancy, at first booking you do, then at 20 weeks and 28 weeks. In subsequent pregnancy, the first pregnancy, then subsequent pregnancies we do, we take the history whether there was a previous pregnancy with no or mild hemolytic disease, and then we do at the first booking. At the first booking for all RH negative lambdas, you have to do an RH test. Then 4 to 6 weeks subsequently, and suppose if this is done 4 to 6 weeks subsequently, if the previous pregnancy had severe hemolytic disease, then titers are not required, and testing, and suppose if the woman had a prior history wherein the severe hemolytic disease is there, then fetal anemia testing should start by 16 to 18 weeks. Suppose if she is ICT negative, everybody is happy, no isoimmunization is present, then how do you manage a non-immunized mother? The aim is minimizing the chances of fetal-maternal hemorrhage, then preventing alloimmunization, you should give an anti-D. So when do we start giving anti-D for an RH negative woman? You give at, suppose at 28 weeks of gestation, ICT is negative, then 300 micrograms of anti-D is given to the mother at 28 weeks. Then within 72 hours of delivery for an RH positive fetus, if the DCT, direct Coombs test, is negative, the baby is, you know, I mean, when you deliver the baby, you want to know what is the blood group of the baby. If the positive fetus is there, you do a DCT, and with the DCT is negative, we want to give anti-D immunoglobulin as soon as possible, or at least within the first 30 days. Then anti-D, it's an IgG antibody. It binds to the fetal RBCs and prevents the stimulation of the maternal immune system. Polyclonal, mostly it is polyclonal. What we have are the preparations are polyclonal. 300 micrograms of anti-D will neutralize 15 ml of fetal RBCs or 30 ml of fetal blood. 50 micrograms neutralizes 2.5 ml of fetal RBCs. Half-life is around 16 to 24 days. It is given on the intramuscularly on either the deltoid or the lateral aspect of the thigh. Dose, usually we go by the dose. Routinely about 50 micrograms is given in the first trimester, and suppose any pregnancy crossing 20 weeks, definitely we want to give 300 micrograms. That is mostly, suppose there is a history of trauma or other history of any abruptio or a placenta previa antepartum hemorrhage which is bleeding, we'd like to give 300 micrograms of anti-D. And the other this thing is, when we want to give is, routinely Kleehor bed case test is not done, but for theoretical sake you need to know what is the Kleehor bed case test to quantify the feto-maternal hemorrhage which is occurring. So what do? We take the maternal blood, and the principle which is applied here is the fetal hemoglobin is more resistant to acid elution than the adult hemoglobin. So these adult hemoglobin is neutralized, so that these cells of the mother act as the host cells in the background. So fetal blood volume, how do you calculate the amount of fetal blood volume is maternal blood volume into maternal hematocrit by the percentage of fetal cells in the Kleehor bed the slide by the newborn hematocrit. 100 micrograms will neutralize 4 ml of feto-maternal blood. So you want to know the feto-maternal blood volume which is present in the maternal sample. This is the formula we use. Maternal blood volume into maternal hematocrit into fetal cells in the Kleehor bed case side by newborn hematocrit. Then metal blood exposed to acid citrate phosphate buffer, and adult cells appear as ghost cells. Fetal cells are brightly stained. So 5 fetal cells in 50 lower power field indicates a feto-maternal hemorrhage of 0.25 ml. Then 80 cells will indicate a feto-maternal hemorrhage of 4 ml, and 100 micrograms of anti-D for 4 ml of feto-maternal hemorrhage. Yeah, so these are the ghost maternal cells, and the bright cells which you see are the fetal cells containing the fetal hemoglobin. Then first trimester, what is the recommended dose? First trimester we give 50 micrograms. Up to second trimester, when you do an amniocentesis or you do second trimester MTP also, you give 300. Only first trimester is 50 micrograms. All the rest we give 300 micrograms. That is equivalent to 1500 international units of RAD. If it is, and so far we have been talking about a negative pregnancy. If it is an ICT positive or an RH isoimmunized pregnancy, then what we assess is the critical titer is assessed. This critical titer is assessed by doing the in serial dilutions. It is assessed, and it is, if it is 1 in 16 or more, if the critical titer is more than 1 in 16, then we do the middle cerebral artery peak systolic velocity. This is called as MCV PSM. MCA PSV. Yeah. So this middle cerebral artery peak systolic velocity, if it is less than 1.5 mean of median, then we deliver at 37 completed weeks. If it is more than 1.5 mean of median, you can wait till 34 weeks and deliver, or after 34 weeks we do a fetal blood sampling. If the hematocrit is more than 30%, you do. If it is less than, I am very sorry, first it is, if it is more than 34 weeks we deliver. If it is less than 34 weeks, you do a fetal blood sampling. If the fetal hematocrit is less than 30%, intrauterine transfusion is given. If the fetal hematocrit is more than 30%, then we do a weekly fetal blood sampling depending on the MCA and peak systolic volume. Then coming to serial amniocentesis and Liley's curve, hemolysis will cause a high levels of bilirubin into the amniotic fluid, amniocentesis, this is not done, but for completion's sake we have to know about the serial amniocentesis. Amniocentesis is done, and the amount of bilirubin which is present in the in the amniotic fluid is quantitated by spectrophotometrically measuring the delta optical density or the optical density at 450 mu. Then here optical density of the amniotic fluid which is seen, there is a increase in the slope, or there is the slope where shows an upward curve at 450 nanometers that is taken. So the difference between the normal the normal amount of bilirubin which is there and the curve at 450 is taken the difference, and that difference is extrapolated into the next slide. This is called as Lilly's charts. So it will, depending on the week of gestation at which this amniocentesis is done, it will fall into one of the zones. So C zone is the most safest zone. C zone is the usually when it increases the zone 1, zone 2 and zone 3, if it falls in zone A, 50%, 56% are unaffected. But whereas zone C is the most dangerous, where you if any of the optical density is falling into zone C, the delivery has to be immediate. Then serial amniocentesis, Lilly's zone, lower zone 2, repeat amniocentesis every 2 to 4 weeks. Upper zone 2, you can repeat amniocentesis 7 days or years. Zone 3, we have to be very careful. There might be a hydramnios or hydrops fetalis. Fetal blood sampling is done. And if the fetal hematocrit is less than 30%, an intrauterine transfusion is done. Fetal hematocrit more than 30%. Then we follow with fetal blood sampling and ultrasound. And when there is lung maturity that is more than 34 weeks, we try to deliver the fetus. Then this is the fetal middle cerebral artery peak systolic velocity, that is MCA PSV. Then intrauterine transfusion. This intrauterine transfusion is given to the affected fetus when the hematocrit is less than 30%. O negative blood is given, cross match with the mother's blood, and tightly packed to achieve a hematocrit. We want to achieve a hematocrit of 75 to 80%. Routes can be given intravascular, intraperitoneal. Intravascular can be into intrahepatic portion of the umbilical vein or the umbilical vein at the insertion of the cord, or intraperitoneal can be the absorption occurs from the diaphragmatic lymphatics. Then this is the intrauterine transfusion. With the help of ultrasound, the umbilical artery is located, and either at the insertion of the cord or into the umbilical vein it is given. Then this is the intrauterine transfusion which is in progress. Then management during delivery. Suppose you are doing a cesarean section and you have an RH negative woman. Then suppose if it is there is a severe form of hemolytic infant disease in the term or 34-35 after previous antenatal prevention of So what we do is, the main thing is we try to prevent spillage of the blood from the placenta into the peritoneal cavity of the mother. So we put green towels all around to isolate the area wherein we are doing surgery. Then spontaneous delivery of the placenta is done, and without any squeezing of the uterus. You should not squeeze the uterus, and manual removal of the placenta is not evident. We wait for the spontaneous expulsion of the placenta, and then we during the vaginal delivery, what we do is induction of labor is performed at term, and during labor, no fundal pushing in the first or second stage of labor. Methergin injection is this is one place where it should not be given. The other place is when a woman is hypertensive, don't give methergin injection. Early cord capping should be done, and no milking of the cord should be done, and no uterine massage. Let the placenta be delivered spontaneously to avoid avulsions of the cord and protect the vagina and perineal wounds and laceration from being exposed to the fetal blood spilled from the cord. So as far as possible, we try to minimize the fetal blood, the positive fetal blood, from contaminating the mother's exposed vessels. Okay. At birth, the maternal blood antibodies can be done tested by doing the indirect Coombs test, and fetal blood cells, red blood cells in maternal circulation. If you want to quantify, you can do the Kleehor-Betke test. Then cord sample, when you collect the cord sample, all RH positive fetuses, you should collect the cord sample. I mean all RH negative mothers who are delivering, the cord sample should be collected, and this should be tested for direct Coombs test, the group of the group and RH typing of the fetus, then the bilirubin level, the infant hemoglobin and hematocrit level. So you need to have 4 bottles ready whenever you are delivering, either by cesarean section or delivering by a normal vaginal delivery. These are the 4 tests. And we should remember that mother, it is always the indirect Coombs, and fetus, it is always the direct Coombs test which is done. Then suppose if the newborn baby is sensitized, if there is only a mild anemia, that is hemoglobin less than 14, you subject the baby to phototherapy, or moderate to severe, it is exchange transfusion. Mild hydrops will improve in most of the cases, but severe hydrops usually has a mortality of 39 to 40%. Okay? This is the baby is receiving a blood transfusion here. Then so RH negative, to summarize, first the husband's blood group is given, at the antenatal checkup, the husband's blood group is noted. If the husband happens to be RH negative like the mother, then you are happy. It can be managed to similar to any other pregnancy. Then suppose if the husband's RH positive, then you send the wife's sample for indirect Coombs test. In case the indirect Coombs test is negative, that means it's a non-immunized pregnancy. ICT in indirect Coombs test is done weekly till 28 weeks. Anti-D is given at the 28th week, provided the indirect Coombs test is negative. Then delivery as per routine indications, and no special, we don't say that you have to do a cesarean section, or you can have the, as long as the woman is non-immunized and the baby is unaffected, it can be treated like any other pregnancy. Postnatal, don't forget to collect the cord blood, and for the 4 tests which we have already enumerated, and give anti-D 300 micrograms to the positive fetus. When you get the blood group, immediately give 300 micrograms. In case it is a positive fetus, the mother should immediately receive 300 micrograms of anti-D. If it is ICT is positive, then you repeat the titers 4 weekly. And when you are repeating the titers, as soon as we know it is a positive fetus, positive ICT, then we send for titers. Titers, if it is more than 1 in 16, then what we do is we go for serial MC, middle cerebral artery Doppler. This, if middle cerebral artery Doppler, if it is more than 1.5 mean of median, then what we do is we routinely, if it is after 37 weeks, we try to deliver her. But suppose if it is less than 37 weeks, then if it is around 20-24 weeks, we can do a chordosynthesis to check for the fetal hematocrit. If the fetal hematocrit is less than 30% and the gestational age is more than 34 weeks, we can deliver. But suppose if the fetal hematocrit is less than 30 weeks and the gestational age is less than 34 weeks, then intrauterine transfusion can be done 1 to 3 weekly, depending on the expected fall of the hematocrit until the 35 weeks, and then deliver urgently to before there is a fetal compromise with hydrops.